Thank you very much, Praveen, for providing this very interesting data. Dr. Apte, what do you think about it?
Yeah. So, Praveen, very interesting paper. So I had a question. When we look at people that did well versus those who didn't well, can you explain the difference and where exactly in the retina were the blebs placed? Were they all started in the same area, and was there any relationship to placement of blebs? Because obviously RP is a full eye process, and we're just measuring central vision.
Yeah, those are great questions, Mike. Here's what I would say. As far as the immediate improvement in visual acuity in some patients and slower in others, I think that's a two-part answer. The first part is biological, and the other one is epidemiological. The biological part is that for an improvement that occurred that early, there had to be a paracrine effect, and I think that confirms the paracrine effect. I think the durability of the effect will more likely confirm the integration effect. So that's the biological answer. In terms of the demographic answer, who improved and who didn't improve as much, this is a small study that's a proof of concept study that showed a biological efficacy signal. I think we'll do larger studies where we'll be able to identify those patients, probably with biomarkers such as OCT and other things that you saw this morning, as to who may improve more, and then be able to select this enhanced patient population. Thus far, all we have is a surrogate, and the surrogate may not be terribly accurate in that's vision. And that sort of is a surrogate or a proxy to us telling us that there may be more photoreceptor cells that are survivable. But again, I look forward to other biomarkers that I think would be much more accurate and objective. And the second part of your question, as far as the bleb is concerned, well, again, with this kind of a procedure, as with gene therapy, I think we all understand that the drugs are so far ahead of the surgical delivery itself. We are creating a potential space. Our imaging is not very good, and we're injecting these drugs in that potential space. And I think we try to get as close to the pathology as possible centrally, but there's no registration and there's no navigation of the location.
Praveen, I had a question about the safety profile. So, the concern here is that there were 2 out of the 7 had pretty significant ocular events. And so what are your thoughts as you look forward in the future trials in terms of reducing this rate, which I think would not be acceptable in the long term?
Yeah, again, this is a proof of concept study, and I think what I'd take from that is that there were clearly some patients who responded early, responded well, others that responded more slowly, but we look and say, what distinguished those patients? Was there some kind of a profile? And as I said earlier on, it'd be great to have a profile that's something other than just vision, and we're looking at that right now. But again, the numbers are small, and I think as we gather more numbers, we'll be able to segregate that more. And again, we've seen the same kind of activity, the same kind of variation in other studies of this kind that have been done as well. So I think if we put all the patients together and we have larger studies, we'll be able to identify those patients in an enriched patient population.
And Praveen, did you look at visual fields or microperimetry or ERG? In
yes.
patient, did you see any signal there?
Yep, all those analyses are currently ongoing. And again, these are just the interim data, but I'll be looking forward to presenting those in a future date. But thank you for the question.
Great, thanks.
Thank you.
Oh, sorry. Thanks very much, Praveen.